Welcome to this explainer. If you're a vestibular physician, a neuroaudiologist, or an advanced trainee working at the deep end of central vestibular practice, well, you're in exactly the right place. Today, we're tackling something that's highly prevalent, frequently misunderstood, but honestly incredibly fascinating: vestibular migraine. We're going to do a really focused, evidence-based breakdown here, taking you straight from the underlying mechanisms right through to practical, bedside diagnosis.
This explainer is based on Vestibular Migraine, a vestibular physician's deep review of mechanism, diagnosis, and management, published by Australian Dizziness clinics.
So here's our game plan for today. We'll kick things off with epidemiology and burden, then look under the hood at trigeminal-vascular pathophysiology. After that, we'll map out the clinical spectrum, break down the Bernie diagnostic criteria, and finally wrap up with targeted investigations.
All right, Section 1, Epidemiology and Burden. Before we get into the weeds, we really need to grasp the sheer scale of this condition: 10%. Think about your waiting room right now. That is the proportion of patients in headache and neurology clinics who actually meet the criteria for vestibular migraine when they're systematically screened. I mean, that's a staggering number, right? In dedicated dizziness clinics, it's roughly 7 to 11%. In fact, we now know vestibular migraine is the single most common cause of recurrent spontaneous vertigo in adults. But here's the catch. Despite affecting nearly 1% of the entire general population, it is still markedly underdiagnosed. And the human cost here, it's massive. We're talking severe anticipatory anxiety, activity avoidance, and major occupational disruption. Most of these patients, they end up on this frustrating carousel, bouncing between different specialists for years before somebody finally gets the diagnosis right.
Moving on to Section 2, trigeminal-vascular pathophysiology.
Okay, let's look at the biological why. How exactly does a migraine disrupt the brain's vestibular circuits? Well, migraine is increasingly understood as a disorder of dysfunctional sensory gating. It's like a chain reaction. It all starts with a baseline genetic susceptibility. Then, boom, classic migraine triggers hit: stress, lack of sleep, hormonal fluctuations. This leads directly to trigeminal-vascular activation, which releases vasoactive neuropeptides, specifically calcitonin gene-related peptide, or CGRP. This chemical surge disrupts your central vestibular circuits, creating this chaotic, multisensory integration mismatch. And the final result for the patient? Episodic vertigo.
Anatomically, what we're looking at is a really fascinating crosstalk. It's happening between the trigeminal-vascular system, your pain pathways, and the central vestibular network. They interact right through those brainstem modulatory nuclei, like the locus coeruleus and the periaqueductal gray. When you get transient dysfunction at these specific nodes, it gates the vestibular signals abnormally, and that's what creates that critical processing mismatch we just talked about.
So, the big clinical takeaway here? You really need to conceptualize vestibular migraine as a migraine that's being expressed through the vestibular circuits, rather than just through the pain system. Looking at it through this specific lens is a real game changer. It predicts exactly why we see central type nystagmus signs acutely, and honestly, it perfectly explains why these patients respond so well to targeted, migraine-directed therapies.
Let's head into Section 3, the clinical spectrum.
Now, here is the biggest hurdle we face in practice: the acephalgic problem. This refers to vestibular migraine attacks that occur completely without a headache. And I really cannot stress this enough. The absence of a headache during the vertigo attack is the #1 reason this diagnosis is missed or mislabeled. Sure, vestibular symptoms and headaches can happen at the exact same time, but they can also be sequential or just entirely dissociated in time. No headache doesn't mean no migraine.
Let's rapidly break down these attack profiles, because they vary a lot. One episode might be this violent rotational vertigo, and the next time, just subtle disequilibrium. The episodes can peak anywhere from 5 minutes up to a grueling 72 hours, triggered spontaneously, positionally, or even visually. Acutely, about 70% of patients are going to show pathologic nystagmus. And crucially, you've got to look at the comorbidities. There's a 50 to 65% rate of anxiety and depression here. Plus, it frequently coexists with PPPD, persistent postural perceptual dizziness, which is that background non-spinning dizziness they feel between the discrete attacks. You absolutely have to screen for this.
Which brings us to a massive red flag. If you have a patient with a prior migraine history, plus stereotyped recurrent vertigo, and they've got photophobia, phonophobia, or a visual aura, even if there's absolutely zero head pain, that specific combination should push vestibular migraine straight to the very top of your differential list. Seriously, do not let the lack of a headache throw you off the trail.
All right, Section 4, bearing diagnostic criteria.
This is your ultimate bedside tool for securing the diagnosis. The Barony criteria are split into two tiers, definite and probable. For definite vestibular migraine, you need at least 5 episodes, a current or prior history of migraines, and migrainous features in at least 50% of those vertigo episodes. Probable vestibular migraine, on the other hand, is for when you strongly suspect it, but the patient only meets one of those 2 migraine-related criteria. It's a really smart system designed to balance sensitivity perfectly against specificity. If you trace the diagnostic logic here, you always start right at the top. Does the patient have recurrent vestibular symptoms? Are they moderate to severe? Do they last between 5 minutes and 72 hours? And have they had at least 5 episodes? If the answer is yes, then you dig into their history. Do they have a prior or current migraine diagnosis? Do they exhibit migraine features in 50% of these vertigo attacks? Following this exclusion process seamlessly drops the patient into either the definite bucket, the probable bucket, or neither. And practically speaking, this is great news, because both definite and probable classifications actually respond to the exact same targeted treatments.
So if you take away one clinical pearl today, commit this to memory. 5 episodes, 5 minutes to 72 hours, a migraine history, migraine features in half the attacks, and nothing else fits better. That is your 5-part Barony checklist. Because we don't have a confirmatory blood test or an MRI for this, this clinical history checklist is hands down the most reliable route to a confident bedside diagnosis.
And finally, Section 5, Targeted Investigations. We need to reframe how we use testing here. Because there is no pathognomonic test for vestibular migraine, our investigations are primarily exclusionary. We're using them to confidently rule out the alternatives. For example, pure tone audiometry is typically normal, but we do it to establish a baseline and exclude Meniere's disease. Vestibular function tests, like VNG or VHIT, we use those to rule out a fixed vestibular loss. They're almost always totally normal between attacks. And an MRI of the brain is utilized specifically to rule out structural lesions, infarcts, or tumors. In a classic textbook presentation, over-investigating is just low yield and honestly should be avoided.
However, you've got to watch out for the absolute red flags. New progressive unilateral hearing loss, persistent downbeat nystagmus without torsion, or any focal neurological signs. These are things that absolutely cannot be attributed to vestibular migraine alone. If you see any of these, it mandates an immediate MRI and a rapid escalation of your differential.
All right, let's tie the whole shebang together. Vestibular migraine is deeply underdiagnosed, yet incredibly prevalent. Its mechanism perfectly bridges the trigeminovascular and central vestibular pathways. Remember the acephalgic problem? Vertigo without a headache is still very often a migraine. Keep the Barony criteria handy as your robust clinical framework at the bedside. And remember, keep your investigations targeted and primarily exclusionary.
So I'll leave you with this to chew on. Are you fully equipped to recognize that silent, acephalgic presentation of vestibular migraine the next time it walks into your clinic? Next time someone comes in with unexplained, recurrent vertigo, look for those migraine features that might be hiding right in plain sight. This concludes our series on vestibular migraine. Make sure to visit AustralianDizzinessClinics.com for the full review and companion materials. Thanks for learning with me today. Keep asking questions, and we'll catch you next time.